Here we are at day 2 of the AATS Mitral Conclave 2015. It's still very busy, as you can hear behind us, and I'm thrilled to be joined by 2 colleagues, very knowledgeable colleagues in the mitral and tricuspid fates. Mr. Frank Wells from Pepworth in Cambridge. Frank, good to see you. And Gilles Dreyfus from the Cardiothoracic Center in Monte Carlo, Monaco. Gilles, good to see you. So the question would come up, and I know you guys are going to talk about this. So we have a 55-year-old male who's got severe MR, primary MR. You're going to repair it. What do you do with the tricuspid? Might have, let's say, a moderate TR or that. So what are you going to do with the tricuspid? Are you going to repair it?
Well, I would, generally speaking, but as we're going to discuss, the evidence is not entirely clear as to the absolute indications for it, and indeed what you can expect the outcome to be when you've done it. And I think if you widen the discussion to perhaps beyond people who are doing a lot of this kind of surgery, to try and disseminate it to the surgical population at large, then it becomes a little more worrying, because there is evidence that there could be increased mortality, morbidity rather, perhaps than mortality. So I think we have to be careful on the advice at the current level of evidence.
So Gilles, how do you make the decision as to, you've written the seminal paper on that, but how do we make the decision on who should or should not have their tricuspid addressed?
I think today, as opposed to the previous message, which was a little bit optimistic and I would say schematic, instead of saying, okay, you have a dilated annulus irrespective of the grading of TR, go and correct it, I would look at some other factors, because I think that we do not emphasize enough that when talking about moderate TR, we do not really know what we're talking about, because the grading is not reliable, and there are whatever paper publications you can't find any real scientific proof of reliable grading. And not only that, is that the grading, even if you had one, the grading is so labile because it depends on so many factors, whereas on the left side, yes, the afterload can change dramatically and then you decrease the degree of functional MR. But on the right side, with so little changes, you can have such an impact on the leak that, I think it's very difficult to rely on the grading. So rather than relying on the grading, yes, my primary concern is I start looking at the tricuspid, irrespective of the grading or regurg, if there is annular dilatation. But then I would probably refine the concept by looking at the leaflet mode of coaptation. And I think this is very important, because if the leaflets have some coaptation edge to edge or no coaptation, or if there is a tenting, then I would be very much in favor of putting a ring.
Would you see, and I'll come back to you in a second, Frank, would you see that lack of coaptation or poor coaptation always in the setting, though, of a dilated tricuspid annulus, or not necessarily?
No, not necessarily. I think this is a very tricky question, and I think you have the answer. But look, I think you're right. There are some patients with tethering who do not even have 40 millimeters or even index 21 millimeter per square meter. I think this is why I like to say it's an entity of the tricuspid, functional tricuspid disease rather than regurgitation. And yes, there is truly the right ventricle has become spherical. Some have individualized AF, female gender, pulmonary hypertension. I'm not sure these factors are strictly correlated.
Frank, what do you think?
Well, I completely agree with Gilles. And of course, we're getting into the whole subject of understanding right ventricular function. And the right ventricle is a tremendous chamber with great capacity for volume accommodation and changes, more than pressure, perhaps like the left side. So the preload and the afterload actually determine so much what is going on, and where you measure this and how you measure it is very, very important. But nonetheless, we do know that patients who've got significant tricuspid regurgitation, let's call it moderate for a better term, call it moderate, left, a significant number of those patients will come back And when they do, it's a very difficult problem to deal with.
It's a threat.
And we all know that there is potentially quite a high mortality because a lot of people will then sit on the fence about offering these patients reoperation.
Or they don't think about. I mean, they're working them up for liver failure, ascites, or things like that.
And I'm sure Gilles, like me, gets offered up every so often a patient who's got severe right-sided failure, whose left-sided valve surgery is working well, but the right ventricle is shot, big liver, swollen ankles, and their lifestyle is severely compromised. What to do next?
So going back to the original question then, so you're going to make a decision before you're in the OR. I mean, does the transthoracic echo help you, or because you've heard me say, and I think that the average echocardiographer, maybe not the guys that work with you all or gals, they don't recognize even how to measure the tricuspid. And you're right, the grading of TR is a joke in most echo reports. So when do you make the determination? You look at the transthoracic, the pre-op TE, and then you're in the OR?
We look at the pre-op transthoracic echo because the loading conditions are the best.
Correct.
And we look at the transesophageal echo prior to going on bypass. But again, I look more than at the annulus size, although even that is volume dependent. But usually I have a report, because the cardiologists working with me are used that there is no mitral valve without a tricuspid assessment. And if the annulus is greater than 40, I am keen to just go ahead and have a look at it.
What about 37? 3.7?
Well, if I wanted to make a
feel like I'm in an auction, don't you?
Well, can I just throw in a ringer here?
I'm sorry.
If you have a patient with a classic severe Barnard's on the left side, and they're 2 square meters or more, how do you decide what to do with an annulus, say, around 40 in the tricuspid position? Because then you've got very different conditions, and often you know better than I that on the tricuspid side you'll have these billowing sort of
there's a balloon on the right side as well.
Yeah, exactly.
Yeah, absolutely.
Yeah.
And you're going to have annular disease with that. So
I think then we come to nearly the next question is there a downside to overcorrect tricuspid annular dilatation? And I think there aren't many. AV block, I think mainly in the papers with AV block during mitral valve surgery plus tricuspid come from the mitral valve annuloplasty or valvular replacement. If you do properly the ring annuloplasty, the likelihood to create a bundle block is very rare.
Or to get into the coronary.
I think the only thing is, as you said, the right coronary artery. This is I check every time I put a ring, the whole aspect of the tricuspid annulus that is going along the posterior leaflet.
Correct.
The right coronary artery can be twisted.
Yep.
And you have to check really that these sutures are not too deep and not kinking the right coronary artery. This can be a lethal condition. This is the only risk I really have.
I think the other thing we have to keep thinking about as well, especially in a forum like this, well, we heard this morning how the majority of surgeons are doing 5-10 mitrals a year. How many tricuspids are they coming across? So the point that Gilles making, this surgery done by someone with great experience, understanding and careful and thoughtful approach is a completely different issue to the average, dare I say it, jobbing surgeon who thinks, oh, we'll just put a ring in and everything will be fine. Because it's much more subtle than that.
So if you have, I'm just trying to clarify in my own thinking, if you have somebody, primary MR, who's got, he's got Barlow's disease and had some runs of AFib, you're going to do, and regardless of the degree of TR, you're going to do him. You do that person.
Absolutely,
okay.
absolutely.
So you have somebody who's got P2 with severe anterior directed jet, mild LA enlargement, but is symptomatic. Let's say that you can prove that they need surgery, but their tricuspid annulus is 3.5, so it's a P2 flail. Would you make the judgment you'd remeasure in the operating room and do all that? You would probably not do that individual?
No, although I said this morning, and I really think that there is work on you and cardiologists to try to redefine this 40 millimeters because they are very rough. and it's not a precise measurement.
No, I understand
And
that.
really, basically it's a four chambers view. You never know where you sit on the tricuspid valve. And this value was, at least it exists. What is the advantage? Exactly, everyone criticized the 70 I described. But at least, it's when you have one figure, you can say, no, this is not right. But when you have no figure,
No.
you're in the
I
middle of
think you're right.
nowhere.
It was a flaccid heart with your fist in there, but
Yeah.
it was a start and said this
Okay,
is what
so-
you got.
Oh, yeah. Well, part of the conundrum here, and there is a direct analogy with functional MR, and that is if you've got ischemic functional MR and you've got recruitable myocardium and you've got mild, maybe mild plus, you're probably going to leave it, revascularize
Correct.
the area and move on. Now turn to the right side in a patient who's got severe left-sided problems. They've begun to get some right-sided distension. They've got some mild, moderate MR. You've got a valve you can completely fix. You know that many of those patients, perhaps most, dare I say, will actually remodel and be fine. So it's a very difficult challenge in the group that you just outlined. I think there I too would leave that alone.
Well, I'm sorry, to cut you off, but
No, that's fine.
the thing that, because I'm seeing a lot of patients, we've talked about this, who are 5-10 years out from an excellent mitral repair who've developed AFib, and they come in with a fair amount of TR with dilated annuluses. They're in AFib. They've had multiple ablations or attempted ablation. I don't know whether they should have been done before, or we don't know that.
Right.
Or we see people who come in like you described earlier, who've
Yeah.
got severe TR, have not been diagnosed. They're in the heart failure clinic and things. Gilles, it's my bias that 3D TE may help, but I really like a transgastric TE view at 60 degrees because I can see, and everybody, I
Exactly.
can see all three leaflets. I can measure
Exactly.
things. I think that may be, even though I don't want everybody to have a TE unless they need one, but I think that's not a bad way to measure the annulus.
I fully support that.
Is that what you guys are doing in Monte
Yeah,
Carlo?
but as you know, transgastric view is not always achievable for the tricuspid, because I think from what I hear, I'm not an echocardiographer, but from what I hear, you need to tilt the probe even more than for the transgastric view. The mitral.
I'll come show your guys
Right,
how to
right.
get that. But you're right. But it is another good view.
It is fantastic. It is a real view of the tricuspid.
A mid-esophageal 4D, 3D picture is not a bad picture too. But anyhow, so the take-home message is you're going to operate on a primary MR. Primary MR, you're going to do that. The decision to do the tricuspid in your mind is what?
Well, it comes down to, I am of the same mind as Gilles, actually. If you've got more than mild, let's call it moderate again, TR, you've got an annulus of around the 40, and
Right.
we can discuss how we
Yeah.
measure that. When we'd measure that, I would do it. I'd put a rigid ring in, and I'd be happy with it.
There's really no downs. You're adding minutes to the operation, and if the point you made, if you know where not to put the sutures for the ring, then it's really not a downside to doing that, is it?
I never downside. I try.
There's not a. I don't mean downsizing the ring. there's not a negative to doing that. I'm sorry. Okay.
No, to me, there's no negative impact. I would like to stress 2 points before we
Okay.
finish. One is that the rings, you realize they have a huge tension, and the only aspect which is really the one which anchors the annuloplasty ring is the septum. And I now add systematically a single stitch to really apply the ring, because you realize that these rings, the tricuspid has a Vanny shape.
Correct.
And the tension on the free wall is huge. We underestimate that. The second point is, I think, when you find yourself with a patient who comes with a secondary TR, edema, ascites, right ventricular failure, a lot of cardiologists and even surgeons say, well, how can we know the patient will tolerate the surgery? And then we come back to the famous Brown valve theory of the pop-off effect of tricuspid regurgitation. Well, I think there I have an answer. We use to measure the stroke volume under the pulmonary artery.
Okay.
And if the stroke volume is viable, for instance, you have 60 milliliters per beat, multiplied by the heart rate, you have a cardiac output of 4.8. Patient is less than 2.2 square meter of body surface area. He has an adequate cardiac output on the right side. he will make it whatever.
Okay.
It might be a bit shaky,
That's
but he will make it.
good point.
Whereas if you find yourself with a stroke volume of 30 under the pulmonary artery, and it has nothing to do with the ejection fraction,
I got it. It's
and if you have 30, then I would be extremely cautious about treating the tricuspid valve.
excellent point.
Mortality becomes very high in those
Excellent
patients.
point.
Just to throw in there as well, in some of our research-oriented institutions, I think there's a role for studying these borderline patients with flow volume loops as well in the cath lab prior to surgery, and trying to understand right ventricular compliance, response to volume load, and so forth. I think we've got a lot to learn, and especially in patients where tethering is a significant factor in the tricuspid regurgitation.
I mean, I think both of you are exactly right. I'm just sitting here thinking, I'm not sure hemodynamics are taught in the cath lab, in the modern cardiac cath labs before. Yeah. So anyhow, it's very important. Listen, you both have added to my knowledge, and Gilles, you've certainly awakened the world to the importance of the tricuspid valve. I think, Frank, you would agree, but thank you both for visiting with me. It's good visiting with us. Thanks very much.
Well, thank you.
Thank you.
To you.
Perfect.